Okay, hello everyone. I think we can begin. So my name is Sergey Kutsenko and I am the expert coordinator of the medical division of Mectron. First of all, I would like to welcome our speaker today, Professor Robiony. He is the chief of the Maxillofacial department of the University of Udine in Italy. Just a second, I mute some people. Okay, so the topic of today's webinar is reconstruction of the temporomandibular joint, customized alloplastic prosthetic total joint systems. The first part of the webinar is the presentation by Professor Robiony, and in the second part of the webinar, he will answer the questions of the participants. I invite everyone to write your questions in the group chat during the presentation or after the presentation. You can find the button which activates the group chat in the lower part of this window. So you can read the chat messages of other people and write your own. From this moment on, I invite everyone to turn off your video and to keep the microphone muted. And I pass the word to Professor Robiony. Professor, could you share your screen again because we cannot see it anymore?
I have to share just a moment now. Okay.
Okay, perfect.
Okay, perfect. Well, thank you, Mectron, for this kind invitation. And today, my topic is reconstruction of temporomandibular joint, customized alloplastic prosthetic total joint system. We perform from long time this type of surgery. In fact, our first prosthetic restoration was made 14 years ago in patient that was submitted to replacement of temporomandibular joint for ankylosis, for post-traumatic ankylosis. Actually, in my daily job, we have an aim and scope to define a new protocol for TMJ prosthesis. Well, in this my presentation, I will present you a new definition of a temporomandibular joint space, like temporomandibular joint compartment, like an anatomical point, a different point of view. Then we talking about the localization of pathology, virtual surgical planning, customized prosthesis, and compartmental restoration. What is TMJ compartment? TMJ compartment is an anatomical part of this important region, which involve from the skin through the bone, through the soft tissue. We have interior part of the joint. You can see in this part the glenoid fossa, like in endoscopic approach. You can see the upper part of temporomandibular joint, the disc and capsule and anterior recess. This represents a part of our compartment. Compartment in our aim is a global joint,
and can be divided in upper part, glenoid fossa and disc and the ligament, and inferior part is the condyle and disc. This concept is well known in orthopedic, in which the joint are considered like compartment, especially in for knee and other articulation. The compartment can be approached in several ways, like endoscopy, open surgery, or prosthesis. Well, now I would like to present a study of Sheen in 1974, in which he present the involvement of pathology, involvement of cranial base, of lateral part of the cranial base that represent the glenoid fossa. In this paper, he presented the total joint with the upper part of glenoid and inferior part of condyle. But when the pathology is advanced pathology is not only ankylosis or fracture or tumor, but also other type of pathology that involve the glenoid fossa. This paper speak about the primary tumor that involve the glenoid fossa, and secondary involve also temporomandibular joint in totally. So this author divided different type of involvement of glenoid fossa, and which we talk when we speak about the temporomandibular joint with involvement fossa, we speak also of surgery of cranial base. This is an important concept. So, in relation to the localization of the pathology, we present you the pathology that involve superior compartment, can involve inferior compartment like condyle, or can involve both upper part and inferior part. For this reason, we speak about we have invented a new name like compartmental restoration, in which we perform a total reconstruction of the temporomandibular joint. Another important topic is the occlusion, because when we perform this type of surgery, we have always considered the occlusal balance. In fact, we have three possibilities. When we perform a substitution of a temporomandibular joint, we can maintain the same occlusion, we can modify the occlusion, or we can correct the malocclusion. And for this reason, we can speak, we can propose three type of surgery. In superior compartment, when we perform a glenoid fossa restoration and cranial base and condyle restoration. Inferior compartment, when the pathology involve only the condyle. Inferior compartment and superior compartment when we speak of ankylosis. The first case that I present you was published in this day in oral and maxillofacial surgical case, a case of chondrocalcinosis. This is an involvement of a superior compartment with involvement of glenoid fossa and so cranial base. So in this paper we present a surgical management and a review of the literature, but it's important to present you the case of a 60-year-old woman that have a chondrocalcinosis. Chondrocalcinosis is a pathology of the soft tissue of the joint, and in this case the soft tissue of the joint are involved especially in the upper part of the glenoid fossa, which with an important involvement of a part of a cranial base, a total glenoid fossa is involved of this process. This is the TAC and RMI that we perform always before to treat this type of patient, and this is another type of view with the CT scan. As you can see, the condyle is not involved directly from the pathology, but when we perform this type of surgery, we restore the upper compartment and also lower compartment, but the pathology is located in the upper part, in upper compartment. So, which are the indications for surgery? The indications for surgery are pain. It's fundamental because the patient have a pain, have a limitation of the open mouth, and erosion of fossa. And so we propose to the patient the compartmental restoration, proposing a custom-made prosthesis. We perform a virtual surgical planning. This virtual surgical planning is fundamental, is necessary when you have to plan exactly a joint restoration, because you have to consider not only the glenoid fossa and the condyle, but also the occlusion. So in this step you can see the glenoid fossa restoration, the condyle restoration, and this is a custom-made restoration. Important part that will be discussed in the, after is related to the cutting guide. This is a part of virtual planning. And this is a virtual planning and intraoperative surgical restoration of glenoid fossa, polyethylene glenoid fossa, and titanium condyle was replaced. At the end of the operation, a CT scan control was made at perfectly and exactly accuracy of the temporomandibular prosthesis positioning, a good mouth opening, and so we had a good and very nice result. Another important case that I would like to show you is a ossifying fibroma of the temporomandibular, of the temporal bone with big involvement of a temporomandibular joint, as you can see in this CT scan and MRI. When we perform this type of surgery, we perform always two examinations, CT scan, MRI, and also sometimes angiography to embolize sometimes internal maxillary artery. The patient is so represented with the tumefaction of a lateral part of temporal bone is evident because the bone erosion is involved all the part until the skin, and we perform a virtual segmentation to plan exactly the resection of a bone tumor. In this part we plan the resection of the tumor and the simultaneous restoration of the zygomatic arch and condyle and fossa with this type of customized During the surgery, we perform an hemicoronal incision, we expose the lesion, remove the temporal muscle, and when the use of the piezosurgery that represents in our surgery a true revolution in bone surgery, because when I use piezosurgery, I can reach a deeper part of a cranial base, a deeper part of soft tissue and delicate anatomical region. So another important thing is that when I use piezosurgery, I can use it simultaneously a navigation, because navigation in this case is fundamental to have exactly and precise performing of ostectomy. Well, using navigation and piezosurgery, we combine two innovation technology that allow us to perform a very big surgery in safety. Also for dura mater, as you can see, dura mater was intact and the osteotomy was performed always and only with piezosurgery, but perfect clean of osteotomic cut line was performed, and this specimen is compared with the simulation that was made before the surgery when we perform a virtual surgical planning. Well, this was the planning and this was the result. It was very impressive because we performed simultaneously restoration of temporal bone, zygomatic arch, zygoma, and condyle. This was a very nice restoration of the compartmental, a new concept of compartmental restoration. This was the patient before and after surgery with a good mouth opening, a good face aesthetic without any damage of facial nerve. Well, this is the check of a CT scan that allow us to check the perfect fit of the prosthesis. This represent, and as you can see in this slide, this is the result of the perfect and good planning, good virtual planning. Inferior compartment of the condyle. Now I present you a patient with lateral deviation, and mandibular lateral deviation caused by slow progressive growth of a mandible, because she had a tumor of the the left condyle and the right mandibular shift and inclination of occlusal plane. Maximum open mouth was 20 millimeters. Well, the occlusion in this case was also restored. He had a third-class malocclusion and facial asymmetry. The problem is that a very big benign tumor of the left condyle that caused this important facial asymmetry. So we perform a one-step surgery, occlusal balance, maxillary mandibular osteotomy, tumor resection, compartmental restoration with the prosthesis. This was the surgical planning, and now I show you all the surgical planning so you can understand well which are the steps in which we perform all our osteotomy. Preoperative view, as you can see, cutting guide for asymmetrically for one osteotomy, asymmetrically for one osteotomy, customized plate. Then we perform a cutting guide, we perform a mandibular surgery, cutting guide for mandibular sagittal split osteotomy, cutting guide to resect the tumor, and mandible repositioning and occlusal restoration. This was a total replacement, including the total joint replacement or compartment replacement associated with orthognathic surgery. The preoperative selective embolization is necessary when you perform this type of surgery in which the tumor involves a medial part in very strict contact with internal maxillary artery and carotid artery. This is a part of surgery that we perform always with using cutting guide, but especially in this osteotomy, it's important to perform using piezosurgery. This is the part of surgery. Also in this part of the mandible, piezosurgery, and especially when we resected the tumor, as you can see, planning and intraoperative view. After the removal of the tumor, we perform and we put inside the customized prosthesis of temporomandibular joint, and in the right part, the customized plate for sagittal split osteotomy. This was the preoperative CT view, planning and post-operative check of the occlusion and of the surgery. This was the patient had a temporary facial palsy because the surgery was very aggressive, but after 2 months the patient was recovery all this situation, a good occlusion, a good mouth opening, as you can see before. Well, in these years, we have published a protocol for fully digital customized management of a concomitant temporomandibular joint replacement and orthognathic surgery. And in our clinic, we perform all a complete step, a flow chart, a complete flow chart to obtain a medical to obtain a digitalized process. In this part of the combination, we perform a combination of clinical and CT scan. We combine a final diagnosis. This is a facial appearance before the surgery. This is the CT scan before the planning. We perform always intraoral scan to have a good occlusion, which we perform the perfect occlusion, a point reference to perform an accurate surgery. And after virtual surgical planning is made simultaneously for orthognathic surgery, a total joint replacement. And this is the completely manufacturing selective laser sintering melting, in which we perform which we use during the surgery. Now it's a pleasure for me to show you a video. Video. This is the incision in inferior part and in temporal area. Inferior incision is made in submandibular, retromandibular approach. The arterial vein, we reach immediately the gonial angle and we detach the masseter muscle. Then we close the incision and we perform a deep superficial approach to reach the joint and to reach the condyle. This is the temporal fascia, zygomatic arch, and we reach the condyle, in which we have to perform a removed disc and attached muscle. And then when with the use of a piezosurgery, we performing cutting of the condyle. We use an insert very thin, 0.5 millimeter of thin. And after this part we perform a total positioning of the temporomandibular joint. This is a cutting guide that allows us to perform a joint resection with use of this cutting guide. We stabilize the cutting guide, and we perform also the hole to perform a final positioning of the prosthesis. And with the use of Piezosurgery, we perform a complete osteotomy until reach the coronoid process, as you can see in this planning, virtual planning. This is the procedure is made in bilateral part. We have a cutting guide also to restore and to place the glenoid fossa. And now I go much more easy. This is the glenoid fossa that is placed in site exactly like it was planned. In this manner, this is virtual planning, and the prosthesis was fixed. Well, and we remove the cutting guide. Then we perform a removal of a part of a cutting guide to place a prosthesis, to place a condyle prosthesis. And you can see, and now I can see you, a perfect placement without any problem to place it, to fix the prosthesis in place. Well, after this part, the procedure is made bilaterally, and we perform also an endoscopic check to have the sensation and to see. This part is important, the perfect contact of our prosthesis. This is a prosthesis that we have modified, and you can see a perfect contact bone prosthesis. Well, the procedure is performed in opposite site, and then we perform also simultaneously orthognathic surgery. Orthognathic surgery is made using a cutting guide. The procedure is made always with Piezosurgery, because Piezosurgery allows us to perform a very thin osteotomy and very precise, especially because cutting guide and Piezosurgery allow us to have a very precise osteotomy. And when we perform this type of surgery, the precision is a must, because we have to obtain a perfect open and down fracture, perfect positioning of the plate that are customized, and perfect occlusion. The mandible is restored, the maxillary is always restored. And at the end of the procedure, we check the occlusion. And at the end, like final procedure, we perform also a genioplasty. I show you a genioplasty like planned, and we'll go very fast, sorry, but it is important to show you the important phase and not only step by step. Fixed the cutting guide, chin osteotomy, and fixation with the plate. The planning was perfectly performed, and so we put inside 2 plates, as you can see. Well, this is the final result. Well, this is the final result before and after surgery. This patient had a condylar resorption because she had a second-class malocclusion. This was the final result in lateral view and frontal view. An important thing is also another paper that we performed, is in press in International Journal of Oral Maxillofacial Surgery, that in which we present you a new cutting guide system that is very important for your surgery. but you will be the opportunity, will have the opportunity to read nextly in the journal Oral Maxillofacial Surgery. Now I present you inferior compartment and superior compartment ankylosis. This patient had a unilateral hypoplasia of the mandible, deviation of the chin, ankylosis probably due to a blood spread of infection in perinatal period. So this patient was before submitted with was submitted to a surgery with the costochondral replacement, but we have a failure of a costochondral replacement after 1 year. And after 1 year, we submitted this young patient and only possible procedure. The consideration of use of alloplastic temporomandibular joint replacement in growing patient was made by Louis Mercury, and we perform this surgery in a young patient, like very not aggressive, but like experimental. But the patient had a very good result. Plainly the right open bite to promote maxillary future growth, and we perform all the steps of the surgery. As you can see, cutting guide, removal of a very big ankylosis, and restoration with temporomandibular customized joint. This is an intraoperative view. As you can see, always we use surgery, especially in young patients, and complete removal of bone ankylosis with a gap arthroplastic, a very nice mouth opening. The final result using also a fat positioned around the prosthesis, and this was the results. Very nice CT scan control with the perfect contact of prosthesis, and this is the patient. Oh, sorry, this is the patient.
Flavia, buongiorno. Bene, fammi vedere come togli l'apparecchietto. Bravissima. Apri la bocca senza apparecchietto. Mamma mia.
Very nice result.
Adesso fai vedere a tutti quanti come metti tu l'apparecchio in bocca. Da sola, guardate.
And this was a splint to help the patient to perform a gym. And this is the last patient that we operated, a very interesting case, a post-traumatic ankylosis, very aggressive. The patient had 5 surgery before our surgery, but not in our hospital. This patient live in Yugoslavia, and this was the open mouth, and this was the video before. Is maximum open mouth because he had an open bite. This is the CT scan, and you can see like a total fusion with the cranial base and a completely fusion, anatomical alteration of an anatomical zygomatic arch and zygoma and cranial base, and the mandible fused with the temporomandibular joint with the cranial base. It's important to perform also angiotac, because in this case we perform also angiography and selective embolization. The planning was very difficult, and in which because we have to perform very different surgery from side, and also the prostheses are very different, and we restore also zygomatic arch. The surgery was very impressive. It's important to perform always tracheostomy. In this case, we perform always percutaneous tracheostomy, because the patients can have a minor morbidity in this case. This is the surgery. During the surgery, this is a part of surgery in which we test the facial movement, because the facial nerve can be involved in this type of surgery. But the final restoration and opening of the patient. This was a very nice, very interesting, very interesting results. It was the final patient that he had a new life. He had a new life, and the patient actually from Yugoslavia, he sent us a lot of letter and other things. Well, in conclusion, compartmental restoration is a new concept that is based on custom-made prosthesis. Balanced occlusion, it is important to remember always that you can maintain same occlusion or can modify occlusion or modify malocclusion. Reconstruction of TMJ has to be considered in skull-based defect involving glenoid fossa. When we perform this type of surgery, we restore also the occlusion, facial appearance, and important quality of the life. The use of alloplastic material for reconstruction in growing patient should be considered also in selective cases, but it is an important option. Thank you for kind attention.
The whole world at our feet, watching seasons change. Our roads were lined with adventure, mountains.
Okay, thank you very much, Professor Robiony.
Okay, thank you.
Everyone can turn on your video now, but keep your microphones muted for now. So I invite participants to write more questions in the group chat if you have any. There are already some in the chat, and I will read them to Professor Robiony. If you also want to ask the question in person, you can either raise your hand, there is an option, or ask for your turn in the group chat. And when your turn comes, I will activate your microphone and invite you for the question. We have the first question here. It's about...
Sergi, fanno le domande a te e tu le fai a me.
Sì.
Ok.
Yes. And
magari tu me le passi in italiano, me le dai in italiano le domande, allora tu.
Siccome i partecipanti parlano inglese, le domande sono scritte in inglese.
Tu magari me le... Ok, vabbè, perfetto, ok.
Ok, poi se qualcuno vuole fare la domanda in persona, attivo il microfono e la fa in persona, ma abbiamo notato che a volte nei webinar...
No, diventa troppo confusionario se attiviamo di persona.
Quindi, so the first question is from coming about the predictability of the surgery. Do you think the piezo is better than traditional tools, instruments for the predictability? Looking at piezo, yeah, so this is the first question, yeah, the other was the second one.
Sorry, can you repeat?
About the predictability of the surgery, do you think piezo is better than traditional instruments?
Yes, the piezo is better than traditional instruments. We perform a lot of study, not only in the restoration of the temporomandibular joint, but especially in orthognathic surgery. Especially in orthognathic surgery, we have substitute completely the traditional cutting instrument, and we perform always all the osteotomy using piezosurgery, especially when we perform the osteotomy of the mandible. It's very safe for the nerve.
Thank you. And then other question is, so piezo has many different advantages. According to different surgeons, they are not the same. So according to you, what are the main 3 advantages, or maybe 2, I don't know, what are the main advantages for you in piezo?
The main advantages for the piezo, using piezo?
Yes.
Yes,
Why,
the main
why you
advantages.
use it?
Allora, with using medical piezo, in general, or especially for TMJ surgery, we have the possibility to reach, for example, a deep part, a blind part of the temporomandibular joint. And when we use piezo, I perform a very safe surgery. This is very important concept. And especially because when we have a bleeding in medial part of the temporomandibular joint, we have a lot of difficulty to manage this. When we use a piezo, we have the sensation to reach the final cut, and this is important. And as you can show before, you had the possibility to see very well, because we have a blood-free surgical site, always. And another thing is very important in my personal experience is a biological aspect. Because the healing of the osteotomic or the clean of the osteotomic surface is very important, because healing of hard and soft tissue is more fast.
Thank you, Professor Robiony. And the next question is about inserts. What are the most common inserts that you used for TMJ?
For TMJ, I use always MT1. I don't remember the name, but it's the same. I showed you before. I don't remember the name of the
MT110. I guess is MT110.
Yes.
But the 0.5 millimeter, 0.3 millimeter, but it's the same. And the in the long 1 centimeter and 2 centimeter. When we have to reach the coronoid process, we use 2 centimeter. And another important insert that I use always is univiere that
Universal. So MT110, MT1S10,
MT1,
MT120, and universal. So you're using the gray and piece basically.
Yeah.
And do you prefer the thin one, 0.3 or 0.5?
0.5. 0.5 when I need to perform a cut much more thin, and 0.3 when we have to perform a little sculpting of a little osteotomy, very thin osteotomy, a little sculpting of the little bone.
Okay, so when the cut is smaller, you use the thinner one, and when a bigger cut, for bigger cut, you use 0.5. Okay, thank you. Then the next question, in your hands, total surgery time is more, less, or the same than traditional tools when you use piezo?
So can you repeat, please?
In your hands, the surgical time is...
Okay. See, yes. No, I perform a lot of study in this special question, because I had the possibility to test in half part of maxillary osteotomy using a traditional cutting tools, and other part using a piezo. The difference is neglectable in consideration of the total duration of the surgery. But I think I perform in 30-second hemi-maxillary osteotomy using piezo, 30 seconds. And when I use saw, for example, but the saw is at the macro vibration, I perform this osteotomy in 5-10 seconds, but second, not hour and not minute, second. So the difference is absolutely not important in my hands. For me, it's more important to have two big advantages. The first is a precise cut, because when we perform orthognathic surgery or total joint replacement, the precision is a must. And then I need another important factor, that biology is important, because in the osteoblasts the osteoclasts are removed fast, and osteoblasts are very active after osteotomy with the piezo.
Thank you. Next question. Are there postoperative advantages for the patients when using piezo?
One of the, it depends. When we perform a traditional orthognathic surgery, for example, without substitution of temporomandibular joint, the very big postoperative advantage is the swelling, is edema and swelling. But when we perform other surgical procedure, this consideration not can be made.
Thank you. Next question.
Especially big advantages is especially when I perform a rhinoplasty. The advantages are very, very, very important. Advantages.
And in rhinoplasty, you also mean swelling?
Swelling and a periorbital edema is very, very, and also ecchymosis and pain, obviously. But a lot of paper are, I wrote a lot of paper in this argument.
Okay, thank you. And the next one, according to you, are there any disadvantages for using piezo?
Disadvantages, but disadvantages for me, actually, if I have to perform, if I have to cut, for example, a very thick bone, and I perform before and first cut using conventional cutting instrument, and then I go with the piezo. But big advantage, disadvantages, I can appreciate.
Most surgeons they say time is a disadvantage.
I use always a piezosurgery, so always a piezosurgery. Also, when I remove impacted third molar, for example, always in my clinic, all of my residents use only piezosurgery, because a new generation have to grow with innovating technology. In fact, in my clinic, we use a combination of piezosurgery with the navigation, with endoscopy, with surgical planning, because I think that we have to improve our quality of surgery. also and also the quality of life of the patients.
Thank you. And the next one is about the cutting guides. Do you always use cutting guides in your surgeries? If not, what is the percentage of surgeries when you use the cutting guides, and which is the reason you don't use them sometimes?
Okay, well, we use the cutting guides always. It is necessary when we perform a total substitution of a temporomandibular joint. It's impossible when you perform a customized surgery. You have use always cutting guide. But when we perform a orthognathic surgery that is planned with virtual planning, but we don't, I don't need always of cutting guide. So in oncological resection of mandibular and simultaneous restoration with the fibula free flap, I use cutting guide. In temporomandibular joint restoration, I use my cutting guide. In all surgery in which we have resect and reconstruct, we have always used cutting guide. Otherwise, you don't have any advantages. In orthognathic surgery, you can, I cannot use.
Okay, thank you, Professor Robiony. And do you perform simple condylar head reshaping with the Piezosurgery device, shaving or reshaping?
Yeah.
And also eminectomies, do you perform with the Piezosurgery, and which inserts do you recommend?
Well, okay. When we perform an open surgery for temporomandibular in temporomandibular joint, we use always a Piezosurgery to cut the upper part of the condyle, because using MTI 0.3 millimeter, we can perform a very thin cut. But also when we perform an eminectomy in open approach, we use Piezosurgery. But in my department, we perform also eminectomy by endoscopy. Under endoscopy, in this case, we don't use Piezosurgery because we don't have the insert that can be positioned through the trocar.
Okay, I think what was meant in the question partially is if you tried the osteoplasty insert, the shaving one, but as far as I understand, you only use the cutting, you don't shave.
It depends. If I preserve, if I would preserve the height of the condyle, I can perform sometimes the reshape, only shape using OP1. I don't remember OP1 yet. And when we have to reduce the condyle, for example, in height condylectomy, that is a procedure that we perform simultaneous to the orthognathic surgery, we perform a cut of condylectomy. But reshape using an OP1, it is a good possibility, a good opportunity to restore the morphology of the condyle.
Okay, thank you. The next question, do you do open, closed, or percutaneous rhinoplasty? Today, you would not do, no, so this is the first question, sorry, the other one is the...
Allora, I perform always the open rhinoplasty. But my original article is proposed using open rhinoplastic and external piezosteotomy. From 2 years, I perform in open rhinoplastic, like proposed by Gerbeau, an internal osteotomy, always using MT1 0.3, and add also irrigation with water, with fresh water.
Yes, and when you do, so according to you, are there any disadvantages to do open in comparison to close?
Opening, but the advantage is not related to the use of piezosurgery, because when I perform an open surgery and my resident, I teach my resident also only an open surgery, because when we perform an open surgery, I have the possibility to see a perfect anatomy of the alar cartilage, the dorsum, the nasal vault, and so all the modification that I perform of this part of the anatomy of the nose can be understood better from my resident.
Yeah, thank you. The next question, today you would not do orthodontic surgery without piezo, is it correct?
Well,
today you would not do orthodontic surgery without piezo. You said it already before. Hello? Hello, Professor Robiony?
I don't think he's hearing us now.
Yeah, there is something with the connection. It was not good before, and but it was actually so one but last question. We were only missing one question. Yes.
Sorry.
Okay.
I had a problem with the connection, but not problem.
Okay, now we can hear you. Actually, we have only one question left, and it's the question says, is piezo a good tool for teaching according to you?
Sorry,
is piezo a good tool for teaching students according to you?
Yeah, in my opinion, yes. Very good option to teach my student, and my student receive also when we use during my use of the piezo, the student have also the opportunity to understand the drawing of the osteotomy, to understand better the thing of the patient, but overall they have the possibility to reflect and to think about the biology of the bone, because when I teach piezosurgery, my student, I start from the biology of the bone. So we have the opportunity, the piezosurgery give us the opportunity to explain better the bone biology. That this part of this important part is not always explained in the past, because in the past, when we use a traditional cutting guide, a traditional cutting bone, you don't have the necessity to explain why I have to use this. Instead, with the piezo, I need to start with the bone biology, why use the piezo, and also for not only for to cutting bone, but also for regenerative aspect, because I have to remember always that piezo start especially for dentistry surgery. And so when we perform a big regenerative surgery using a medical piezo device, this concept is important that the surgeon have to have this concept, this biological concept.
Yeah. Thank you very much, Professor Robiony. There are no more questions in our chat, and we are perfect in time. It's 9 o'clock. It's 19 o'clock.
Perfetto.
I give maybe Renato wants to say a few words.
Yes. Thank you, Sergei. I just want to thank Massimo Robiony for the very professional and enthusiastic presentation. Listening to you, you can feel how convinced you are of the technology, how, let's say, I would say in love you are with the technology. And this is a very important aspect of this presentation. I also want to thank all of the participants, and for the last time, if anybody has additional question, please make yourself visible and ask the question. Otherwise, we just say hello to everybody.
Grazie.
Grazie.
Grazie a tutti.
Grazie, professore.
Grazie.
Thank you.
Grazie a voi.
Ciao Massimo, grazie.
Arrivederci.
Thank
Ciao
you.
Renato, grazie a te. Grazie.
Grazie, Prof.